The jejunal pouch, though appears to be very promising in terms of storage of food, and but the technique is very, very challenging, and it also comes with a lot of challenges like residual food being present in the stomach, in the pouch, and also most of the patients experience a lot of complications with this procedure. So now I don't think many would advocate this particular procedure now. So the discussion now coming to the main reconstruction procedure is double tube reconstruction, and also a modification of that. So we take the first part of the jejunum, about 20 centimeters from the ligament of Treves, and then it is anastomosis to the stomach, esophagus, and also a second anastomosis is done into the stomach, where the food can be passed into the stomach also. And last, towards the distal side, the jejunal anastomosis is performed, where the bile and biliopancreatic juices are channeled back into the jejunum. So this is a very good procedure, whereas a small modification to this procedure is done by firing a stapler just beyond the anastomosis between the jejunum and the stomach, by which the food is just channelized into the stomach and through that into the biliopancreatic limb and into the jejunum back in. So this is called a single track jejunal interposition anastomosis. So now I want to show a small video here. So the food is getting channelized. This is a study, contrast study, where the food is being given to the patient, and then you can see that the stomach, there's the entry also into the stomach and also into the jejunum. So the stomach also receives 3% of the 3/3 of the food, and jejunum will also receive 2/3 of the food directly when ingested. So coming to the literature, we have plenty of literature comparing all these three studies, so all these three procedures, but I will make it short. So if you can see this table, the stenosis rates are higher in case of esophagogastrostomy, and reflux is also very high in the case of esophagogastrostomy, whereas the double-tract jejunal anastomosis clearly comes as a winner in terms of stenosis and reflux esophagitis. So after analyzing this data, we can say that the jejunal interposition is the better method in terms of stenosis and in terms of lower reflux esophagitis. Coming to the reconstruction of distal gastrectomy, we all know that there are three main procedures, which is number one is Billroth I, Billroth II, which is again polya, where the anastomosis is done in the entire length of the limb, and Fenester, where the anastomosis is done at a small part. So, and the Roux-en-Y anastomosis. So now, since with the latest, more usage of laparoscopy, which is being done for doing gastrectomies, we can do a modified anastomosis between stomach and the duodenum called delta stapler anastomosis, which is proposed by Kanaya. And also we can use a circular stapler to do these anastomosis. So in Billroth I, clearly it is a very simple procedure with only one anastomosis. It ensures that there is a physiological route for the passage of food, and also it is also easy to do a post-operative endoscopy in case of any problem with the papilla of Vater. But on the other hand, we have a lot of dumping which can happen into the stomach, rapid gastric emptying which can happen, which can result into duodeноgastric and gastroesophageal reflux, and also the remnant gastritis, remnant stomach can develop gastritis, and also lower end of the esophagus can develop esophagitis, which can progress again further back into cancer, becoming cancer. There's also higher fistula rates in case of gastroduodenostomy because of excessive devascularization or mobilization when the duodenal stump is being mobilized to do the anastomosis. So for distal gastrectomy, the choice is essentially between two procedures, that is Billroth II and Roux-en-Y reconstruction. So I'll go short here. I'll not discuss much on the process of or technique of gastrojejunectomy. Definitely the Roux-en-Y and Billroth II gastrojejunectomies are the preferred methods. But both of them or any of these procedures have got a plethora of complications which can happen. And to cut short that, the Roux-en-Y reconstruction has definitely shown much promising results than rest of the two procedures. and significantly decreases the reflux symptoms and also reflux gastritis and esophagitis. The quality of life definitely improves with the Roux-en-Y reconstruction rather than Billroth and Billroth II. So there are various meta-analyses and studies which have been done in the past to show that Roux-en-Y has definitely less bile reflux and remnant gastritis. But one procedure which we have already spoken in the morning, someone has spoken about this, a Braun procedure, which we commonly do when a Billroth II is done, just to minimize the reflux. On long term, it shows to be not very good procedure, as you know, the patients will develop symptoms in the long term in spite of doing a Braun. So with that, I conclude this topic. Thank you. I invite you all for this liver talk, where we are conducting this program on behalf of Star Hospitals on 30th of August and 31st of August, where we will be discussing in entire scenarios of complex recipients, how to manage them, and there will be a lot of debates and discussions. I invite you for this event. Thank you very much.